From the KPFK studios in Southern California,
it's the Ralph Nader Radio Hour.
Stand up, you've been sitting way too long.
Welcome to the Ralph Nader Radio Hour. I'm Steve Scrovan, coming to you once again from Mumbai, India. My co-host David Feldman from New York City, and the man of the hour, Ralph Nader from Washington, D.C. David, tell us who is our first guest today.
Our special guest is Dr. Charles Blatt. He's a cardiologist at the Lown Cardiovascular Center, which is dedicated to the diagnosis, prevention, and non-invasive treatment of various cardiac conditions. Dr. Blatt's clinical work is focused on the management of patients with coronary and valvular heart disease, atrial fibrillation, and the impact of psychological stress upon the heart. He has directed several research projects focusing on the roles of depression and anxiety in coronary artery disease. He is also an assistant clinical professor of medicine at Harvard Medical School. Ralph, please welcome Dr. Charles Blatt.
With great delight, I welcome Dr. Charles Blatt. I want to give a little context here. We read about, in the healthcare system in America, of perverse incentives, where there often is overdiagnosis, over-operations, over-prescription of drugs, and less emphasis on prevention and non-invasive procedures. The Lown Center came to my attention when a friend of my sister's, who was diagnosed and prepared for a heart operation, went to the Lown Center. And with the diagnostic skill of the doctors there in Brookline, Massachusetts, she was advised in a non-invasive way and avoided a very serious invasive heart operation. Since then, we've had people go to the center with similar successful results. The center does not operate. It is not a hospital. It is a diagnostic center. And so I want to begin with you, Dr. Blatt, in the context of enormous unnecessary expenditures and pain and anguish from unnecessary surgeries. I want to first ask you quickly, how did the Lown Center get started, and what's your philosophy?
Yes, the Lown Center started back in the early 60s, and it grew out of the practice of Dr. Samuel Levine, who was known as the father of American cardiology. A little caveat is he was in India, I think in Mumbai or Delhi, where one of our hosts is sitting, when President Eisenhower had his heart surgery and had his myocardial infarction, his heart attack, and they were unable to reach him, so therefore they reached Paul Dudley White, who Dr. Levine had taught. So Dr. Levine was really a master of cardiology, and one of his students for 12 years was Dr. Bernard Lown. And the Lown Cardiovascular Center as a clinical practice started at the time that Dr. Lown finished his training with Dr. Levine. And the current four senior members of the group are all trained by Dr. Lown and did fellowship work at the Brigham and Women's Hospital. And it has grown with a component of research work and teaching as well as an active clinical practice.
And your philosophy, the way one of your mottos is, and this is a nonprofit center, by the way, and Lown is spelled L-O-W-N. Your philosophy was compressed in one short phrase, doing more for our patients and less to our patients. Would you want to elaborate on that, Dr. Blatt?
Yes. The concept of doing more for rather than to really implies spending the time to really understand the patient as a human being and focusing on a careful taking of a history of speaking with the person, taking the time to sit down eye to eye rather than the doctor standing at the end of the examining table, but sitting together, getting the history, and taking the time to get the details and the nuances. And we almost always have, and at least encourage, that a patient bring his or her spouse or significant other to the office visit, especially the first time, because one learns a great deal about a patient and what's really going on with them from that interaction. And often when the patient is the man if the wife is a female, often brings much more to the table, and we learn that much more. But the essence is the carefulness of the history and probing into the details. And that is the time-consuming and costly component. Not costly to the patient because the insurers really don't pay very much for that. The perverse incentive that you mentioned is that the insurers would rather pay for the procedures that the doctor then decides to do, and often those procedures are advised because there was not the time taken by a careful history to understand whether they were needed or not. So it's a very basic philosophy of doctoring, of developing a relationship with a patient, of understanding their clinical history by doing a thorough hands-on physical exam, which I'm surprised when I hear patients, I'm amazed often when I hear patients say they've been to 3-4 doctors and they're seeing me for a third or fourth opinion, and no one has really ever listened to them as long as I have, nor have they placed a stethoscope on their chest often. So we prize those fundamentals and learn often enough to allow us not to go to an invasive procedure like a cardiac catheterization, rather adjust medications, devise a proper exercise program or diet, or often deal with the very important psychological aspects of the patient's illness or of their complaints.
Stress, you mean?
And the stress, correct. Now, I have to explain to you, we are not in any way opposed to moving ahead and often very promptly to a cardiac catheterization or an invasive intervention or moving ahead to bypass surgery or valve replacement. And I do so in a very regular manner. But when I do so, I know and I am satisfied that the risk that I'm pushing my patients to accept with that type of intervention is really worth that risk, that I have not done so in any cavalier fashion, and I've not done so because I have not taken a careful history.
More and more patients, Dr. Blatt, are telling us that they go to a doctor and the doctor's looking at a computer screen rather than the patient. I mean, what you're really saying is you're focusing on the patient, and a lot of patients you get are there for second opinions. Can you give some concrete examples without mentioning the actual names of the patients of how your approach of the Lown Cardiovascular Center has avoided more invasive procedures?
Well, indeed, I was asked to see a patient who was due to have bypass surgery following week. And indeed, he arrived in my office, and we started to talk together. And in about 10 minutes, and this was a medical professional as well, he started to look at his clock, at his watch on his wrist. And I said, what are you doing? He says, well, I'm due to give my blood. I have to donate my blood at the blood bank in order for my operation. And I said to him, well, I'm here to give you an honest second opinion, not to rubber stamp the direction to surgery. And he said, well, you've already spent more time with me than I have spent with my primary care doctor, my cardiologist, and the fellow who did the cardiac cath. So I said, well, in order to give you a careful and thorough evaluation to see whether you need this operation, which could be a life-threatening process if something goes wrong, I need about an hour. And he said, go ahead. And I took that history, I examined him, I sat down with him. Turned out he had not been given some very fundamental medications that are used to treat heart pain, also called angina pectoris, Greek term for pain in the chest. And once I devised a program for him, 17 years later, I saw him last month. I had seen him actually every 6 months during that interval, but I just most recently saw him, and it's been 17 years since his second opinion. He's doing his medical practice. He has a habit of going to the gymnasium or to the swimming pool 4 to 5 days a week. I encourage that. I had him use a sublingual nitroglycerin tablet under his tongue before he begins his exercise. I restored his confidence in the fact that he could exercise without this chest pain. I also did something that many doctors are frightened of doing, and I must say I learned this from Dr. Lown, is I confronted with him the issue of sudden death, Sudden death is what most patients are very frightened of, and often it's left unsaid. And the problem that we often confront is that a person has had a diagnostic procedure, a cardiac catheterization already, and has been shown those cardiac catheterization films which show a narrowing. And they're told that their life is hanging by that thin thread of blood passing through a narrowed vessel, or that they have a widowmaker in their chest. And those words and those images put a hex upon the patient, and they're unable to get by that. And it takes a lot of work to reestablish their own confidence in themselves. Now, there are some very important signs that say a patient should not proceed along those non-invasive lines, and that they should indeed go to bypass surgery. So we really define those criteria for moving ahead to an invasive approach. And we learned from our careful studies that we published during the late 60s, 70s, and into the early 90s in a series of articles that 80% of bypass surgery during that era was essentially unnecessary.
80%?
80%. Now, I mentioned that it was during that era because things have changed. Our approach was considered heretical at that time, but fortunately, many institutions, and I'm most familiar with most of the institutions in the northeast of the United States, have come to adopt our approach and in general approach the matter of when to move towards bypass surgery in a way that's similar to ours. I mentioned that figure of 80% to draw your attention to the fact that this was an enormous, enormous problem that has gotten better, but remains a significant problem nonetheless.
Dr. Blatt, could you comment on the use of stents? Are they overused now by the cardiology profession or properly used?
Well, the use of stents has been a major advance, I must tell you. But a stent is an intervention or the placement of a stent that helps alleviate chest pain. It does not prevent heart attack or prevent death. So one has to recognize that with the use of these interventions, one does not prevent the most serious consequences. And therefore, the choice of who gets a stent has to be carefully approached. One would rather use those medicines which work in a systemic way. By that I mean a general way, approaching the entire circulation to the heart, all of the arteries to the heart, rather than just that distinct narrowing that is causing problems and causing discomfort. The analogy I give to patients is that we can put a stent in and open that area up, but if we don't treat aggressively the process that led to that narrowing, a new narrowing may occur a centimeter downstream or a centimeter upstream of where that first process. So the relief of symptoms can be achieved quite promptly, but it doesn't give us the ability to not treat very carefully, treat with proper medicines, diet, exercise, and relieve the stress that probably in most people is the source of it all.
Dr. Blatt, did I hear you right when the patient you talked about said that after you spent 10 minutes and went to an hour with him, that he was recommended for heart surgery by doctors who spent 10 minutes or less with him?
Yes, that's correct.
That's really extraordinary. And once you made a comment that in terms of what you charge, it compares favorably with a plumber's charge. Do you want to elaborate on that?
Well, that's correct. What we have a practice that serves Medicare patients. About 65% of our population is Medicare. And the reimbursement for a full hour sitting with a patient is about $140. And I think if you get a plumber to your home for a full hour, at least in the Boston area, you can't get away with that cost.
That reduction by the government in January 2010, the CMS and the U.S. government reduced by 35 to 40% the reimbursement rate for non-invasive cardiac testing if it's performed outside of hospitals. So is it true that now you have an incentive for cardiology practices to stop being independent and to get under a hospital umbrella because they can charge more? It seems to be completely irrational And of course, it disadvantaged your preventive approach. Can you elaborate that?
Well, you're exactly right. And we were faced with a financial catastrophe at that point because of the fact that 65% of our patients are Medicare, and we lost 35 to 40% of the revenue we used for exercise testing, for an echocardiogram, all the non-invasive tests we use to determine if a patient requires the invasive and costly tests. So what happened indeed was practices like ours that are outpatient practices not aligned with a hospital found that they were being put out of business. And I think I've heard this figure, although I can't vouch for its accuracy, that maybe up to 60% of practices either went out of business or aligned themselves with a hospital, where they were then able to charge about twice or three times as much for the exact same diagnostic test.
And
so
then,
CMS wound up shooting themselves in the foot, and they realized a couple of years, 3 years later, that their expenses for doing these non-invasive tests rose enormously. And because these practices came under the roof of a hospital.
There's the perversity again. A majority of cardiovascular practices have now affiliated with hospitals so they can charge more for the same practice. That is what Steve Brill is alluding to. The cover story of Time magazine, Dr. Blatt, you may have seen it this week.
Yes, I read it, yes.
Yes, he said he had a $195,000 open heart surgery, and he uses that as an avenue to discuss the enormous charges and inefficiency and waste and sometimes very unethical practices by the whole industry, the healthcare industry. Do you think it's important to tell your patients what to avoid when they come to your office, what to avoid discussing with their doctor or when they come to your office?
Well, what we do ask them to avoid is being confused about the essentials. So we ask them in advance to prepare a list of medicines that they're taking and to have it in front of them in writing so that we don't spend that time trying to figure out whether there's a blue pill and what the blue pill means or the white pill, but to do their homework in advance. Most of the patients are very good about that, but we give them instructions. We ask them, if they can, to bring the information that they've accumulated with regard to outside test results and recent blood work so that we can more quickly and efficiently put their situation into context and decide the appropriate path to follow. We ask them, as I mentioned earlier, that they should try to bring a significant other with them. First of all, the information that goes back and forth can be totally overwhelming, especially to a person who's not versed in these medical issues. And most patients aren't and really are not expected to be. But having a second set of ears to listen is very important. And then we try to arrange for a follow-up in a reasonable amount of time, a follow-up appointment to be sure that there has been an accurate understanding of what we've asked them to do. Now, we do have a lot of patients who come here to our center from all over the country. I have several from around the world. I just saw 3 patients in a row from Paris with atrial fibrillation. And that's another very common entity that we do a lot of work in. And they were told they needed ablation, another very invasive, intrusive, and expensive procedure to otherwise treat what can be a benign rhythm disorder if managed properly. So we do have a lot of patients who come, and we ask them to come prepared with the material that they have accumulated from outside institutions. I hope this answers or goes to the point that you were bringing up.
Yes, very much so. In fact, we put out a publication years ago, How to Help Your Doctor Help You. And that's the spirit of my question. I understand you've designed a course and teach a course to fourth-year medical students at Harvard University in outpatient cardiology. What have you witnessed in terms of the students' reaction to the kind of course you're teaching?
Well, it's been a very rewarding experience for me over the past 12 years. I've directed this course, and and it's often oversubscribed, and the students are thirsty for this kind of experience. They often tell me that it's the first time in their medical school career, and I see them in their fourth year as an elective. During the month they spend with me, they say they've not witnessed another doctor just sitting and talking with a patient, spending that time, and then taking the time to use a hands-on, old-fashioned medical approach. And they just astounded, and they want to do this. And they find that their typical training has been in hospital settings where one sees very ill patients but gets a rather skewed perspective on how one is to manage the vast majority of patients who are taken care of on the in an outpatient setting. So it's been a very rewarding experience for me as well as for my students, and they get to see a hands-on approach to doctoring.
And to sort of try to make sure, if I get this right, there's a lot of pluses to new medical technology, but it's getting in the way at times between the doctor and the patient. And what the students get in your course is you cannot allow the technology to dominate and intrude on the judgment of the doctor, who should be directly communicating back and forth with the patient on a personal basis.
That's exactly right. One has to be capable of knowing what technology is available, what its strengths and weaknesses are, what it will really tell you, and also always be thinking 1, 2, or 3 steps ahead. If one gets a test, what are you going to do with the results? What kind of potential false positive or false negative result will you be looking at? How will you be diverted off from the real problem at hand? And will you be able to clearly look the patient in the eye if a complication emerges from that intervention, that it was truly and absolutely necessary? So as a doctor, you have to make some difficult decisions and often put your patient at risk when you recommend that they proceed with an invasive procedure, be it diagnostic or a therapeutic procedure. You have to be able to do that and be comfortable that you've exhausted every skill you have. And the first skills of doctoring are listening.
You also see patients who have had open heart surgery. You see patients after invasive procedures too, don't you?
Oh, yes. And as I mentioned, our group will often need to send our patients for these invasive procedures, major bypass procedures, heart valve procedures, and interventions using a catheter and placement of stents. So we are able to take advantage of the most advanced high-tech medicine and do so very readily, but choose the patient correctly.
Before I ask you the ultimate question on single payer, which is supported by a majority of doctors, nurses, and the American people over the years, that means full Medicare for all, everybody in, nobody out, free choice of doctor and hospital. Can you give the contact website for the Lown Cardiovascular Center and where people can get your newsletter and find out in more detail what you're offering?
Yes, I'll give you the contact. It's www.lowncenter.org. And another source is info@lowncenter.org.
And that's spelled LOWN, right?
Correct. LOWN, one word, LOWNCENTER.org.
Okay. And we all know the comparison between countries, especially in the West, in terms of how much is spent on average per patient a year. They have varieties of single payer. Canada is public funding and private delivery of healthcare, and they are spending about $4,500 a year per capita, and they cover everybody in Canada from birth to the demise. And we're spending now over $9,000 per capita. There's still about 42 million people who are not covered at all. And there's some studies by Steffi Wollender and David Himmelstein, who taught at Harvard Medical School for a number of years.
I know them.
Yes, that the outcomes are even better in Canada. What's your opinion on what's called single payer? And there's a good website on that, singlepayeraction.org. What's your opinion on that to replace the present really incredibly wasteful and harmful system? I mean, thousands of people die every year because they cannot afford health insurance to get diagnosed and treated in time.
Well, I am absolutely fully in support of Medicare for all. It was the simplest solution for us to introduce to this country, and all we had to do was gradually approach it to make the age for becoming eligible for Medicare at 55. And within next year, we drop it to 54. 10 years, you're down to 45. Actually, I would think it could be done on a much more accelerated path than that. And then move from the coverage of children, move from age, what it is now is 26, but it used to be 21, and move from 26 on up to 36, and very quickly you narrow the gap and get everybody covered. And this would allow for the bureaucracy to catch up with all the new enrollees. I also don't think it's bad to pay a tax for a service. And we're paying enormous taxes to private health insurance companies, and they are trying to really cheat us in every way they can, from narrowing down what they will cover for increasing their co-pays, increasing their deductible, which they are able to do in an arbitrary way. And this just happened to the faculty at Harvard University. And my health care all of a sudden became, in an arbitrary way, vastly more expensive. So I would be absolutely in favor of a single-payer Medicare. We have a system in place and simply expand it in an efficient manner to cover the entire population.
Full Medicare for all, everybody,
Cool.
Nobody out. Free choice of doctor and hospital, which most Americans don't have with these tightening networks that are becoming absurdly restrictive in terms of the doctors and hospitals you can go to, even under
Exactly.
Obamacare. And the other point that's really, we did 21 examples of how Canadians respond to their health care and how Americans have to respond to their health care insurance. For example, Canadians never have to worry about whether they're going to change jobs depending on whether they're going to have health insurance. In the United States, it has reached the absurd level where some poor people create misdemeanors in order to be put in jail so they can get health care. You can see the whole list of 21 on singlepayeraction.org. And it relates completely to the quality of life and stress and anxiety that is so much lower in Canada than the United States.
I agree with you 1,000%.
Dr. Blatt, I wanted to ask if you are in the minority in doctors on this issue, and if so, why?
You know, I must confess I don't know the current statistics on this, but among my colleagues, I rarely meet somebody who is not in favor of a single-payer system. It would be so much easier for each of us. Those who are practicing within a hospital have an enormous buffer and a bureaucracy which buffers them from the difficulty of managing their practice. But people who are doing it on an independent way, an independent manner as we are, because we did not want to be told by a larger institution how many minutes we would spend with the patient and what our throughput should be. We wanted to maintain the humanity of taking care of patients in the way that we would want to be taken care of. And so we see patients, new patients for a full hour. We see patients who come back for either a 30 or a 45-minute visit. And you see that this is financially a recipe for disaster with the current situation. Fortunately, we have some patients who have seen the brilliance of this and the fact that they've avoided surgery and have been willing to help support that type of activity. I think that it shouldn't be that way. It should be that the system rewards with a proper amount of reimbursement so that an office could function with enough personnel so that we could answer the telephone and that we get back to people the very same day, and that if they need to be seen, they're told to come in. We see them in the office rather than the emergency room so that we can hopefully be more effective. Now, if it's an emergent problem and requires emergency room, by all means, they're told to go by ambulance immediately to the emergency room. But if you can deal with the majority of problems outside the hospital setting, and we strive to do that whenever possible. So
another way of saying it is emphasizing prevention. And prevention doesn't get reimbursed like $195,000 open heart surgery for Steve Brill on the cover of Time magazine. That's the perverse incentive, wouldn't you say?
That's right. If a doctor understands that there's an enormous anxiety or a terrible depression has befallen a patient that is the source of the aggravation of the symptoms and doesn't deal with that and get them the proper help from another professional or deal with it in a humane manner, the underlying problem is only going to accelerate and get worse and eventually require the much more expensive and dangerous solution. We call it management of problems, not just a treatment or an intervention, but the management of the entire situation. And the psychological component of what is ailing a person is a terribly important one, and it can't be shortchanged. And we have patients who tell us time and time again that they don't want to go anywhere else because they never have had a chance to sit and talk with a doctor like they are able to do here. Yet because we don't do all the invasive procedures and are honest brokers, and when it comes to if a procedure is necessary, are being forced out of existence.
Well, Dr. Fred Hyde, who probably knows more about hospitals and how they're run than any doctor in America, he cures sick hospitals. He looked over your practice, and he told me, when I asked him, what do you think of Lown Cardiovascular Center? He said, I think it's elegant. And so I want to thank you very much, Dr. Blatt, for being with us today. And before you leave, can you give your contact information once more?
Yes. I'll give you the online contact number is via www.lowncenter.org. That's LOWNCENTER.org. We are located in Brookline, Massachusetts at 21 Longwood Avenue, Brookline, Mass. 02446. And our phone is 617-732-1318.
Very good. Thank you very much. And we hope to continue this with other types of practices that focus on prevention, excellence, and the public service of the medical profession. Thank you very much, Dr. Blatt.
Thank you. Bye-bye.
Bye.
We've been talking to Dr. Charles Blatt from the Lown Cardiovascular Center, lowncenter.org. You're listening to the Ralph Nader Radio Hour. We'll be back right after this.
Stand up, you've been sitting way too long. Stand up, oh, step up, rise up.
From Pacifica, you're listening to the Ralph Nader Radio Hour, www.nader.org.
Oh, step up, rise up.
Welcome back to the Ralph Nader Radio Hour. I'm Steve Scrovan along with David Feldman and Ralph Nader. Now, Ralph, I know you're a supporter of small business, and there are a number of new enterprises out there with names like the Snuggery, Cuddle Comfort, the Snuggle House, the Cuddle Connection, and Snuggle Buddies, and none of those are any of the groups you started. But they offer services of professional cuddlers. And like for $80 an hour, $400 a night, someone will cuddle you in a purely platonic way, they claim. And I don't know, to me, it sounds like a cross between, it's right in that sweet spot between a Thai massage and a lap dance. I don't know. What do you think, Ralph?
Well, my information comes from a Wall Street Journal article. It was page one article called Professional Cuddlers Embrace More Clients. It was by a reporter whose last name was quite appropriate. Her name is Stephanie Armour.
Okay.
And she starts out by profiling Kimberly Kilbride, who's a professional cuddler, for $80 an hour up to $400 for an overnight gig. The 33-year-old mother of three dons flannel pajama bottoms, puts away her family pictures and two pit bull mixed dogs, and invites clients into her bedroom in Highland, New York, to snuggle. Once the spooning starts, she insists that it stay strictly platonic. Apparently, it's spreading like wildfire. People feel lonely, sometimes for quite legitimate reasons. For example, there's a picture where there's a cuddler for an elderly woman who wants reassurance. One free app, listen to this, Cuddler, Cuddlr, was launched in September and has already had 240,000 downloads. So obviously it raises problems. I mean, the Cuddlers, for obvious reasons, are not licensed. It's kind of a freelance business. There are all kinds of permutations. There's some fear it might attract unsavory patrons. Some patrons are more suggestive than the Cuddlers allow them to be. It does tell us something about loneliness in America. There are all kinds of stories in this Wall Street Journal article that indicate how it's radiated in all kinds of ways and contingencies and surprises. However, nothing is stopping its growth. And there are now organizations like CuddleCon in Portland, Miss Hess, Hess, sponsoring the first ever cuddling event that will feature speakers on touch communication, pillow fights, and massage classes. Now, there's a larger lesson here.
Yeah.
And it's this. Our economy has increased in worker productivity 20-fold in the last 100 years, adjusted for inflation. And so the question is, why is so much poverty? Why is so much deprivation? Why are the necessities an economy should deliver, adequate housing, health care, nutritious food, inexpensive energy, transportation, public transit, whatever, why are these necessities still in great need while the economy is exploding in all kinds of peripheral responses to whims and wants? Well, clearly, a lot of the 20-fold increase in productivity is going to the top 1% super rich. That's one reason why we haven't abolished poverty in this country. It's very, very skewed in inequality to the top 2%, 5%, et cetera. The second reason is that so much of the economy has drifted away from responding to the necessities of the American people and into the wants and whims, and more into the whims. And an example of that is the Consumer Electronics Show, that gigantic show that's just concluding in Las Vegas, annual show.
Uh-huh.
And I had my associate, Matt Marin, look through some of the offerings because I caught a commentary when the show started by an observer there saying he didn't see any real innovations, any real significant technologies. What he saw was a lot of peripheral stuff that's the sort of, it's called technical fluff. And Matt Marin has come up with examples of the trivia. I mean, it's almost hard to describe it because it's technical. But how about this one? It's called Spy on and Play with Your Pet from Afar While You're at Work with Pet Cube. That's the name of the project, Pet Cube.
Uh-huh.
It's basically a nanny cam for pets. So you turn it on before you go to work, and your cat or dog remains alone, and you can look at your cat and dog. It's only $199. You look at it. It's a 138-degree wide-angle camera that streams HD 720p video to your smartphone. And not only that, but it has a cool feature, says the promoter. It gives you the option to play with your pet when you're at work or you're outside the house, because it builds in the Pet Cube a laser pointer that you can control with your iPhone or Android.
Wow.
What's this about not providing clean drinking water to tens of millions of Americans? Okay,
Yeah.
here's another one. I kid you not. It's called the Selfie Brush. It's a hairbrush on one side and a smartphone on the other. I mean, why pick up a hairbrush? You can do a selfie and then scratch your hair. This is at Las Vegas.
Right.
Then there's something known as the log bar. The log bar is arguably the worst Kickstarter project ever, according to a commentator. It's a giant ring that's supposed to give us sci-fi movie-like powers over everyday objects, which will be at the show, hopefully showing attendees at the show that it totally works, and all those reviews that say it's a scam are wrong. Then there's the gem phones. Oh, this one. Here's the come on for you to buy it. Have you ever wished your headphones were glitzier? Maybe blended in at the club more easily? Well, I certainly hope you haven't. But if you have, then you're going to want to check out gem phones, jewelry earphones, and they're very fancy in a Claire's sort of way. One last trivia. The Lamborghini 88 Tari. Now watch this. If you can't shell out a few $100,000 for a Lamborghini, you can always shell out just a few thousand instead to the Lamborghini phone. If you need a $6,000 Android Power phone, this one's for you. Aside from its 1080p high-resolution 5-inch screen, it comes with an Android 4.4 KitKat and a 20-megapixel camera. Men, what's this about? You can't find the decent toaster in America yet? You can't find the kind of products that are really product worthy that people need? But go to Las Vegas and you'll get fills with trivial techno-twit technology.
I maintain that I'm incapable of going into a shopping mall and buying something for my own personal pleasure, and unless it's work related. If it's a computer,
or it's a cuddle,
cuddle.
Right.
Yeah.
Ralph, have you ever strolled into a mall, bought something impulsively that was not work related and not a book, and couldn't wait to bring it home and play with it?
Yes.
First of all, Ralph, you've strolled into a mall? That's the part I don't believe.
I've strode into a mall. The sun was out. There had not been a cloud for 3 days, and I rushed and bought an umbrella.
Of course.
Because the sun had been out for so long, they had discounts on umbrellas. So I brought the umbrella home and twirled it.
See, there's our consumer. There's our consumer.
So listen, I want to bring the comedian out of both of you. What do you think of all this trivial stuff?
Well,
I mean, do you think it reduces stress?
Well, wait a second.
Takes money away from psychiatrists? What do you think?
I'm looking for an app on my iPhone to be funny. Hang on.
Yeah. Well, yeah, I think it's more distraction. It's more distraction. And what I want to know is, was there anything good that came out of this Consumer Electronics show? Anything not trivial?
Well, it's interesting. Apple boycotts it. And there wasn't anything I read of any breakthrough in a functional way to meet a real need, I mean, for example, there are all kinds of curlicues on things you can put on your wrist and belt to measure how many steps you take, what your high blood pressure is, how many calories you're ingesting. But, pretty soon we're going to outsource the brain, right? We're outsource common sense, right? But where's the humor in all this, you guys? Give us humor. Feed it to Colbert and Jon Stewart,
Ralph, yes. That's a hard way to get laughs. To tell us. Where's the humor? You're a lousy warm-up comedian is what I'm trying to tell you.
That's right. In other words, make a joke doesn't work.
Right.
That's right.
I mean, do you think, would the Occupational Safety and Hazard Administration ever been in effect if somebody walked up to you and said, make us safer at work, Ralph? It had to come naturally.
Well, that's right. You had to get it sideways. Somebody had to fall down. You had to laugh. And then you go, wait a minute, let's fix this.
Well, what I hear are agonized screams and cries of great pain. But you're all motivated differently, I know. Now, let's take some serious thing. You want to discuss the Paris situation?
Yes, Ralph, I wanted to tell you about, because David, I think, has an interesting take on it. And I think
I'd rather hear Ralph's take on it.
I would rather hear your take and have Ralph respond to your take first. What do you think about that? You willing to go out on that limb, David?
Well,
You can put it in context, David.
well, obviously, Charlie Hebdo, it's a tragedy. It goes without saying. I just question the wisdom of going out of your way to antagonize an oppressed minority in your country. My feeling is there are 5 million Arabs in France. 70% of their prisons are filled by Muslims. They're an aggrieved party. What is the purpose of satire? Why would you kick down and antagonize a group of people who are extraordinarily sensitive? And I don't consider it's satire to go after radical Islam. I think if your country is already at war with radical Islam, that's not satire, it's propaganda.
And what figure did you come out in terms of terrorist incidents in Europe by comparison?
There was an article, in fact, I'm going to interview the professor later today. 2% of all terrorism in the EU is Islamic, radical Islam. The rest are separatist factions.
Like what?
Well, I guess like Basque separatists, groups who want to secede from a specific part of their country, independence.
Well, this is obviously a ghastly tragedy, but Jonathan Turley, who's a professor of law, we're going to have him on someday on this show at George Washington University. He's a litigator on human rights. He's a great professor of law. This Sunday in the Washington Post, he wrote an article, and the headline was, "The biggest threat to French free speech isn't terrorism, it's the government of France." And he goes into considerable detail. This is Jonathan Turley, Turley, and he analyzes 3 French statutes on the books that criminalize speech in a whole variety of ways. I think he's almost an absolutist in free speech. But people have been convicted and sent to jail for speech unrelated to inciting violent crime. He says France's appetite for speech control has only grown. And he gives an example where recent speech regulation in France has not only expanded into non-hate speech, but the courts are routinely intervening in matters of opinion. For example, and I'm quoting Jonathan Turley, last year, a French court fined blogger Caroline Dudet and ordered her to change a headline to reduce its prominence on Google for her negative review of a restaurant. And he says, while France long ago got rid of its blasphemy laws, there's precious little difference for speakers and authors in prosecutions for defamation or hate speech. And so he makes the point that there's a double standard here, and it should be addressed. He said it was the growing French intolerance of free speech that motivated the staff of Charlie Hebdo, and particularly its editor, Stéphane Charbonnier, who made fun of all religions with irreverent cartoons and editorials. And so I think the lesson is, let's broaden the context, let's drop the discriminatory hypocrisy or discrimination, and address the whole issue of free speech, nonviolence, open debate, and focus on the coercive efforts of government, which in its repressive nature can find eruptions of violence that are fairly attributed to that kind of repression. So I urge you all, and by the way, he says, quote, the French, of course, have not been alone in rolling back protections on free speech. Britain, Canada, and other nations have joined them. We have similar rumblings here in the United States. It's a very good article, Washington Post, January 8th, by Professor Jonathan Turley, Turley.
Do you believe there's such thing as a hate crime in America?
There's hate speech. The question for civil libertarians is, should it be a crime if it doesn't incite violent action? For example, you cannot falsely shout fire in a crowded theater and then create a panic and people get hurt. The person who does that can't say, oh, I'm exercising my First Amendment freedom. So it's always a matter of where do you draw the line. Most legal scholars are extremely protective of disgusting speech and the kind of speech that, you would find repulsive. Because as Anthony Lewis has said in his last book, the great columnist for the New York Times, he basically said that if you can't protect speech by those who hate you, you're not an advocate of free speech. Of course, that goes back to Voltaire saying, I may disagree with you, but I'll fight to the end to protect your right to say it. Having said that, we've got to start asking what leads to these kinds of violent eruptions. Is it money? Not in the Paris case. Is it a sense of grievance? Is it a personality aberration? We just don't like to go into explanations. Is it because they have relatives in the Arab world who've been killed by drones or by U.S. invasion of Iraq? All that kind of discussion is considered taboo. It's really quite interesting. The focus is on the massacre. It should be focused on, of course. But then if you don't understand why people engage in that kind of behavior, and you simply approach it with brute force and collective punishment of a lot of innocents who happen to have the same funny sounding last names, you're only going to spread that kind of behavior.
I was interviewing somebody in Paris earlier today, and they told me it is against the law in France to say Charlie Hebdo deserved to be attacked.
Yes, that's called criminalization of hate speech. That's true. That's not the case yet in the United States. I think when you have a First Amendment with a lot of judicial decisions and is constitutionally based, you're much more likely to defend against erosions of free speech than in a place like Britain, which does really not have a written constitution. It has judicial precedents, but it's very important to have explicit, I think, protections like the First Amendment to our Constitution.
And then our love of the First Amendment gets perverted by Citizens United.
And by the Patriot Act, whose notorious provisions are up for renewal in June of this year. So alert yourself to your member of Congress, folks. Give them your feedback on the Patriot Act. This is a left-right area. I had it in my book, Unstoppable, the Left-Right Alliance. This is where left-right, libertarians, liberals, progressives, authentic conservatives want to eliminate the intrusion into your library card borrowings and to be able to have the government under the Patriot Act to search your home and not tell you for 72 hours. That's an outrage.
Well, very good. I think we have enough time to take one listener question. So let's do that for a Facebook question. This is from Dan Nauman, who asks, do you feel that a big economic crash is inevitable, and what kinds of alliances can be created to reach the masses with thoughtful, factual messages?
Well, I can't predict an economic crash is inevitable because you have socialism bailing out capitalism. At our big rally in Wall Street a few years ago, we had a big sign, socialism bailing out capitalism, otherwise known as bailing out Wall Street on the backs of U.S. taxpayers via Uncle Sam. That's the system we have in place. We've got to recognize it, that without socialism bailing out capitalism, capitalism would have collapsed about every decade in these banking crises and rampant speculation with other people's money like pension money. So is a big economic crash inevitable? There may be a crash, but you, the taxpayers, are going to have the safety net on your back, not to mention growing unemployment from such a crash. What kind of alliances? I think if you read my book, you'll see all kinds of alliances, left, right, back home, people you don't ordinarily associate with politically or electorally. But on these issues, and I have 24 issues, which include the issue of bailing out Wall Street, there's a huge majority of left-right saying break up the big banks, break up any corporation that's too big to fail, and crashes on the taxpayer's back.
Well, thank you, Dan Nauman, for that Facebook question.
We have another question?
Caroline McNabb writes, how can we outlaw fracking unilaterally in the most effective way to avoid our water being polluted?
It's just been done in New York State. Grassroots rallies, protests, brilliant scientific information by people like Walter Hang of Ithaca, New York, going to Albany, contacting the legislatures, putting pressure on Governor Andrew Cuomo. And what happened? A few days ago, he announced fracking is prohibited in New York State. Our water, our land are too important to allow fracking in that state. So that's the way you do it. Contact Walter Hang. He'll show you step by step on how it was done in New York State.
And 2 weeks ago on this very show, we talked to Walter Hang, who we spent about 45 minutes. He gave us the whole template there. So check out that show. Check out Walter's website, toxicstargeting.org. And guess what, people? We've come to the end of another Ralph Nader Radio Hour. It was another fast hour, great hour with Dr. Charles Blatt. On behalf of David Feldman and Ralph Nader, I'm Steve Scrovan. Join us again next week.
Thank you very much, Steve and David, and thank the growing audience for this hour. We're very gratified by your listening to what we have to say and being stimulated for citizen action.
Stand up, you've been sitting way too long.
From Pacifica, you've been listening to the Ralph Nader Radio Hour, www.nader.org.
Special thanks to John Richard, Matthew Marin.
Our graphic designer is Jimmy Lee Wirt. Our editor is Jimmy Lee Wirt. Our board operator is Jimmy Lee Wirt.
Oh, what the hell. Let's make him our producer.
Our producer is Jimmy Lee Wirt.
And thanks to our executive producer, Alan Minsky.
And most importantly, special thanks to Mr. Ralph Nader, www.nader.org.
Our theme music, Stand Up, Rise Up, is written and performed by Kemp Harris.
If you're listening to the Ralph Nader Radio Hour as a podcast and would like to listen to it as a broadcast,
call your local radio station and say, I want the Ralph Nader Radio Hour.
He's Steve Scrovan.
I'm Steve Scrovan. He's David Feldman.
Until next time.
Say you're tired of trying. You say we have no choice. Say you're just one person, and who will hear your voice? Don't let them fool you. You have the power in your hand. I'm only trying to school you. Listen to me, people. Do you understand? We gotta stand up. Oh, you've been sitting way too